Hello there. So we were studying epidemiology and we'll continue with that. We'll go further. So let's begin. So now here we have a 22-year-old woman who presents in the GP with symptoms of acute sinusitis. The current statistical benefit of antibiotic use in acute sinusitis is given. Numbers needed to treat for a course of antibiotic fall between 7 and 21. Numbers needed to harm for a course of antibiotics fall between 8 and 11. So what does these numbers which need to harm mean? Okay, let me just go through the options first. Numbers needed to harm for a course of antibiotics. So the numbers needed to harm can be defined as the number of individuals which must be treated so that one of them has an adverse reaction accountable to the treatment. The adverse reaction could be as small as episodes of diarrhea, or it could be as severe as an anaphylactic reaction. So, so we have to keep in mind this definition. Numbers needed to harm. So this is a takeaway point here. And we'll also go through acute sinusitis. Uh, Numbers needed to harm. Numbers needed to harm can be defined as the number of individuals that must be treated so that one of them has an adverse reaction accountable to the treatment. So it is the number of individuals which must be treated so that one of them has an adverse reaction accountable to the treatment. So here if it is given 8 to 11, the numbers needed to harm for a course of antibiotics is between 8 to 11. That means for every 8 to 11 people who take antibiotics, one person would have an adverse reaction which is accountable to the treatment. That is the numbers needed to harm. So the numbers which must be completed, which must be accomplished to cause harm to one individual because of the side effects of the treatment, which is accountable to the treatment. So numbers needed to harm can be defined as the number of individuals which must be treated by the treatment so that one of them develops or has an adverse reaction which is accountable to the treatment. Now this adverse reaction can range from adverse reaction can range from diarrhea to anaphylaxis. So vast majority this we as we were dealing with acute sinusitis. So vast majority of acute sinusitis is caused by viruses. So the numbers needed to harm is higher than the numbers needed to treat. So before you prescribe any antibiotics for acute sinusitis, think twice. And here we'll also go through acute sinusitis. Acute sinusitis is mainly caused by viruses and only 2% are caused by bacterial infections. It is mainly caused by viruses and only 2% caused by bacterial infections. Clinical features. Clinical features include nasal congestion and discharge, nasal congestion and discharge, facial pressure, and reduced sense of smell. So clinical features would be nasal congestion, discharge, facial pressure, and reduced sense of smell. Now, it is not easy to distinguish bacterial from viral infections, but there are certain features which can sway you towards thinking of bacterial infections. If one or two of these features, it is still to be considered viral, but more of these features more likely that it is a bacterial infection. So one or more of the following features indicates presence of bacterial infection rather than viral infection. These features are symptoms lasting more than 10 days, discolored or purulent discharge, nasal obviously, discolored or purulent nasal discharge, unilateral pain, fever greater than 38 degrees Celsius. So these features indicates or supports the presence of bacterial infection. More features will be present, more are the chances of the presence of bacterial infection. These features are presence of fever more than 38 degrees Celsius and unilateral pain and symptoms extending more than 10 days extending more than 10 days, and discolored or purulent nasal discharge. So they will indicate the presence of bacterial source of sinusitis, bacterial infection which is causing acute sinusitis rather than viral infection. Most uncomplicated bacterial sinusitis are self-limiting too, so we have to be cautious when prescribing antibiotics. So even most uncomplicated cases of bacterial sinusitis are self-limiting in nature. So it's important to be cautious when prescribing antibiotics. Now the management. Management of acute sinusitis. First, if symptoms are lasting less than 10 days, do not prescribe antibiotics unless complicated acute sinusitis. Paracetamol, paracetamol, ibuprofen for pain relief, nasal saline, nasal decongestant, do not recommend oral decongestants, do not recommend oral decongestants, antihistamines, mucolytics, or steam inhalation. These are not recommended. No evidence, as there is no evidence. So we do not recommend oral decongestants, antihistaminics, antihistamines, mucolytics, and steam inhalation. Now, if symptoms are more than 10 days, extending for more than 10 days, then nasal steroids for 14 days, still likely viral, although a backup antibiotic prescription is reasonable. Still likely it is viral, although a backup antibiotic prescription is reasonable at this time. So, advice should be given to use only if symptoms rapidly worsen or do not improve within 7 days. So, advice should be given to use only if symptoms worsen rapidly or do not improve within 7 days. So, antibiotics should rarely be prescribed, but if required, antibiotics rarely prescribed, but if required, then choice would be phenoxymethylpenicillin. Phenoxymethylpenicillin. Antibiotics choice for the systemically unwell is coamoxiclav. Choice for the systemically unwell would be coamoxiclav. So, antibiotics choice, usually antibiotics are rarely prescribed, but if required, then the choice of antibiotic would be phenoxymethylpenicillin, and choice of antibiotic for systemically unwell would be coamoxiclav. Now, for complicated acute sinusitis, it can range from high risk individuals systemically unwell to ones with intraorbital or periorbital or intracranial complications. It would be obvious that reassurance will not be the answer, as they would present with features such as periorbital edema, cellulitis, displaced eyeball, double vision, or swelling over the frontal bone. These are rare, so it is unlikely that such situations are asked, but the gist is these patients would either need antibiotics or admission into the hospital. Yes. So the thing is, complicated cases are rare, but when present, then are given antibiotics or admission to the hospital into the hospital. These complicated cases can have can be systemically unwell, can have intra or peri orbital or even intracranial complications. And these complications can be like cellulitis, periorbital edema, displaced eyeball, double vision. There can be swelling over the frontal bone, variety of things. So, regarding acute sinusitis, it is mainly caused by viruses. Only 2% are caused by bacterial infections. Clinical features would be nasal congestion, nasal discharge. Clinical features would be nasal congestion, nasal discharge, facial pressure, and reduced sense of smell. Uh, and another important thing is that to distinguish between bacterial and viral infection is not easy, but there are certain features which we have to focus on. More will be the presence of these features, more are the chances that the acute sinusitis is bacterial in source. Uh, and these features can be like fever greater than 38 degrees Celsius, symptoms lasting for more than 10 days, unilateral pain, discolored or purulent nasal discharge. So these are the things which will point towards bacterial infection. But even the most of these bacterial sinusitis cases, most of these uncomplicated bacterial sinusitis cases, these are also self-limiting in nature. Therefore, we have to be very cautious while prescribing antibiotics. Now, when we come to the management part, when we come to the management part, uh, if symptoms are the treatment depends on the duration of symptoms and severity of the symptom. Duration and severity. Now, if symptoms are lasting less than 10 days, then do not prescribe antibiotics unless it is a case of complicated acute sinusitis. Paracetamol, ibuprofen are given for pain relief. Nasal saline is given, can be given. Nasal decongestants can be given. Do not recommend oral decongestants or steam inhalation, mucolytic agents, antihistamines. Do not recommend all these things. Just and do not uh, prescribe antibiotics unless it is a complicated case of acute sinusitis. Only paracetamol, ibuprofen are given for pain relief. Nasal saline can be given. Nasal decongestant can be given. We do not recommend oral decongestant, antihistamines, mucolytics, or steam inhalation as we don't have enough evidence to support all that. But if symptoms are lasting more than 10 days, then we have to give nasal steroids for 14 days. If symptoms are lasting for more than 10 days, then we have to give nasal steroids for 14 days. And although still there are chances that the infection is viral, but we have to consider certain backup antibiotics by this time, because it is very reasonable to actually think of prescribing certain antibiotics when symptoms are lasting for more than 10 days. So along with these nasal steroids which are given for 14 days, we will also have a backup antibiotic prescription. But advice should be given to the patient to take those antibiotics only if the symptoms are worsening rapidly or if there is no improvement even after 7 days. If there is no improvement within 7 days. So nasal steroids, if symptoms are more than 10 days, lasting for more than 10 days, then nasal steroids for 14 days and backup antibiotic prescription. Advice is given regarding taking those antibiotics only if symptoms are worsening rapidly or they do not improve within 7 days. So antibiotics are rarely prescribed in the case of acute sinusitis, only given when complicated case of acute sinusitis is present. But in case we have to prescribe antibiotics, the antibiotic of choice would be phenoxymethylpenicillin. The anti If we have to prescribe an antibiotic in complicated case of acute sinusitis, then the antibiotic of choice would be phenoxymethylpenicillin, and antibiotic of choice for the systemically unwell would be coamoxiclav. Antibiotic of choice for the systemically unwell would be coamoxiclav. So complicated cases are rare, but when complicated acute sinusitis cases can range from high risk individuals systemically unwell to ones with intraorbital, periorbital, or intracranial complications. They can be high risk individuals, systemically unwell, or ones with intraorbital, periorbital, or intracranial complication. So it would be obvious that only reassurance would not work in such cases. Uh, as there would be features such as periorbital edema, cellulitis, displaced eyeball, double vision, swelling over the frontal bone. These are rare, so it is unlikely to be asked, but the gist is that these patients would either need antibiotics or admission into the hospital. Talking about numbers needed to harm, it can be defined as the number of individuals which must be treated so that one of them develops an adverse reaction accountable to the treatment. The adverse reaction can be as small as episodes of diarrhea or anaphylaxis. It's the number of individuals which must be treated so that one of them has an adverse reaction accountable to the treatment. As it is caused by viruses, so the numbers needed to harm is higher than the numbers needed to treat. Okay, so let's move ahead. Let's move ahead now. A new study was conducted to investigate the benefit of extending the age of survival in women having a new cervical smear test. It involved women above 65 years of age who attended their cervical screening regularly, irregularly, or not at all in 5 years prior to their diagnosis of cervical cancer. Using a wide database, the reports statistically showed improvements in overall survival, and this new cervical smear test was associated with increased survival. The 5 year survival rate was 91% amongst the women with regular screening, 88% in women with irregular screening, and 84% in women without screening. So, what type of bias could have led to this result? So, here what we are focusing on is bias when it comes to such studies. So, let's now study about bias. Bias is any deviation from the truth caused by an error in gathering participants, performing the study, or interpreting data. So, it is any deviation from the truth caused by an error in gathering participants, conducting the study, or interpreting data. Now, there are certain specific types of bias which we have to focus here in relation to the exam. First one is selection bias. Selection bias Selection bias is where a study uses a poor technique of randomization. Selection bias, it is where a study uses poor technique of randomization. For example, a COVID vaccine trial where two groups are selected. The first group, which is selected as a treatment group, are healthy young 21-year-olds, and the second group, which is a control group, are elderly with multiple comorbidities. It would be obvious that the treatment group would do well if you compare both the groups against the likelihood of death from COVID. Example, selecting two groups for vaccine trial where one is consisting of young healthy individuals and another is having old individuals with comorbidities. So this is what selection bias is. Selection bias is where a study uses a poor technique of randomization. So selection bias basically means there is a poor technique of randomization. For example, so we are not selecting the groups properly. There is a poor technique of randomization. Such bias is called a selection bias. For example, two groups are there for testing for vaccine trial. One group is consisting of young healthy individuals, another is having old individual with multiple comorbidities. So it is obvious that the treatment group which is given this vaccine would do well, and there are more chances of them to survive against the other group. Now let's study about sampling bias. Sampling bias can be classified as a subtype of selection bias. It is a subtype of selection bias, but may also be considered separately. So as sampling bias clearly indicates, there is problem with the sampling which has caused bias. Sampling means selecting the samples or the groups. So sampling bias can be synonymously used with selection bias. Now, another bias, another type of bias is confounding bias. Confounding bias occurs confounding bias occurs when the correlation that we observe is affected by another factor that we have not considered. It occurs when the correlation that we observe is affected by another factor which we have not considered. For example, when you follow a group of people who drink coffee to determine who will develop lung cancer, you might conclude that drinking coffee makes you 5 times more at risk of developing cancer than those who do not drink coffee. What you are missing is that the people who drink coffee are more likely to smoke than people who do not drink coffee. So, smoking was the unconsidered factor that caused lung cancer here. So, this is what confounding bias means. It occurs when the correlation that we observe is affected by another factor which we have not considered. Example: Group A, coffee drinkers, having more chances to develop lung cancer than Group B, non coffee drinkers. What we missed here is that coffee drinkers are more likely to be smokers, to be smoking than non coffee drinkers. So, smoking was the unconsidered factor here. So, this is what confounding bias means. It occurs when the correlation which we are trying to study or which we are observing is also affected by another factor which we have not considered at all. This leads to confounding bias. Here, example is coffee drinkers having more chance of developing lung cancer than those who do not drink coffee. But we miss that people who drink coffee are more likely to smoke than the people who do not drink coffee. So smoking was not considered, was the unconsidered factor which caused the lung cancer. So it occurs when correlation that which we are trying to study or which we are observing is affected by another factor which is not considered. Example: smoking here. Another type of bias is recall bias. Now, recall bias occurs when people participating in a specific study are more or less likely to recall the information on exposure depending on their outcome status. It is sometimes referred to as response bias as well. Let us go on to an example. For example, there was a study that studied the relationship between exposure of someone coughing in the same room and later developing COVID 19. Those who develop COVID 19 are likely to search their memories for that person who coughed in their face, whereas those who did not develop COVID 19 would not even have bothered searching their memories. This leads to a recall bias, and the study would conclude that sitting in a room with someone coughing increasing the chances of being infected by COVID 19. So, this is recall bias or response bias. So, basically, what it tells is that the people who have not developed COVID 19 or SARS and COVID, uh, these people would not bother to remember or recall their memories of someone who coughed on their face, who coughed in their face. Whereas the people who have developed COVID 19, they are more likely to recall such incidents. So we will come to an observation, or we will come to a conclusion that there are more chances of developing COVID 19 when we are sitting in a room with someone coughing. But that is involving this bias along with it, this study. So, recall bias, it occurs when people participating in a specific study are more or less likely to recall information on exposure depending on their outcome status, whether they have developed the disease or not. Example, people who developed COVID 19 are more likely to recall and search their memories for a person who coughed in their vicinity, whereas people who have not developed COVID 19 are less likely to do that. So, this will lead to recall bias, and study would conclude that sitting in a room with someone coughing increases chances of getting infected by COVID-19. So, this is recall bias or response bias. It occurs when people participating in a specific study are more or less likely to recall the information on exposure depending on their outcomes. When people participating in a specific study are more or less likely to recall the information on their exposure depending on their outcome. For example, people who develop COVID-19 are more likely to recall their history or their memory of being sitting in a room with a person coughing as compared to the people who have not developed COVID-19. They will have a hard time recalling such memories. So this will lead to a recall bias or response bias, and the study would falsely conclude that sitting in a room with people coughing would increase the chances of getting COVID-19 infection. So this is recall bias. Now, confirmation bias. Confirmation bias is the tendency to search for, interpret, favor, recall information in a way which supports the views hold that they already hold. For example, debate over gun control in the US. A person that supports gun control would seek out news that reaffirms the need for limiting gun ownership. Social media platforms may even push stories to her that she is likely to read which are in support of gun control. On the other hand, another person who opposes gun control may seek out news that is aligned with his beliefs. Social media platforms are likely to push stories that he will read which are opposing gun control, and he may only remember details that uphold his beliefs. Unfortunately, this type of bias prevents us from looking at situations objectively, even in experiments. So, this is confirmation bias. It is the tendency to search for, interpret, favor, and recall information in a way which supports the views that they already hold. So, it's like having a personal inclination towards something which you already confirm that you already support something, and it's kind of unfair, and because of that personal inclination you tend to interpret the data accordingly, and you tend to favor the side and recall information in a way which supports your views which you already have. There is a tendency to search for, interpret, favor, and recall information in a way that supports the views that they already hold. Example: person supporting gun control would seek news that reaffirms limiting gun ownership and even social media platforms push more stories in support of the view, whereas person who opposes gun control will seek out news that is aligned with his or her beliefs. Means they oppose gun control, so definitely they will seek out for news that is aligned with their beliefs of removing the gun control and security and safety issues. And social media platforms will push more stories opposing gun control. So this type of bias will prevent us from looking at the situations objectively in the experiments. This type of bias prevents conducting experiments objectively. Now, so confirmation bias is when a person already confirms their beliefs, their personal inclination, their personal views, and it is the tendency to search for, interpret, and favor and recall information in a way which supports the views which are already held. And for example, a person supporting gun control would seek out news which limit gun ownership, and even social media platform would push such stories, whereas a person who opposes gun control will seek out news which is aligned with their beliefs of limiting or opposing the gun control, social media platform will also push more stories opposing gun control. So it will prevent us from looking at the situations objectively in such experiments. It is a tendency to search for, interpret, and favor and recall information in a way that supports the views which are already held. Confirmation bias. Now, lead time bias. Lead time bias occurs when survival time appears longer because the diagnosis was made earlier. The definition of lead time is the duration of time between detection of the disease by screening or new experimental criteria and its usual clinical presentation and diagnosis through the traditional criteria. Basically, it is the time between an earlier detection through screening and the time in which diagnosis would have been made in the usual clinical manner. The reason that it can lead to a bias is that if researchers start counting years of survival from the date of diagnosis, moving the date of diagnosis earlier will make it seem like the survival appears longer. For example, a pancreatic cancer patient where screening was not available developed symptoms at the age 65 and died at 70 years old. The patient lived 5 years after the diagnosis. However, if there was a screening test that somehow picked up his diagnosis at the age of 60 before he developed symptoms, he still died at 70. The patient now lived 10 years after the diagnosis. He did not live longer because of the earlier detection. He still died at age 70, but one may interpret this as as if he lived longer because there were 10 years between his diagnosis of pancreatic cancer and his death. So, lead time bias. It occurs when survival time appears longer because the diagnosis was made earlier. First, we have to understand what is lead time. Lead time is the duration of time between detection of the disease by screening or new experimental criteria and its usual clinical presentation and diagnosis by the traditional criteria. So it is the time between an earlier detection through screening And time, it is the time between an earlier detection through screening and time in which diagnosis would have been made in the usual clinical manner. Time interval between the earlier detection through screening and the time in which the diagnosis would have been made in the usual clinical manner. This is called lead time. So it can lead to bias because if researchers start counting years of life for survival from the date of diagnosis, moving the date of diagnosis will make it seem like the survival appears longer. L- Moving the rate of diagnosis will make it seem like the survival is longer. For example, if there is a pancreatic cancer patient where screening was not available when he developed symptoms at the age of 65, died at 70 years old, the patient lived 5 years after the diagnosis. However, if there was a screening test which somehow picked up his diagnosis at the age of 60 before he developed symptoms, he still died at the age of 70. The patient now lived 10 years after the diagnosis. He did not live longer because of earlier diagnosis. He still died at age 70. But one may interpret this as if he lived longer because there was 10 years between his diagnosis of pancreatic cancer and his death. In summary, lead time bias is when a better screening tool for a specific non treatable disease makes you think that early detection has increased the survival rate of the patient, but it really has not. To avoid a lead time bias, ensure the researchers look at the age related mortality rates and not survival. So, lead time bias is when better screening tool for a specific non treatable disease makes you think that early detection has increased the survival rate. of the patients, but in reality, it hasn't. To avoid lead time bias, ensure that the researchers look at the age related age related mortality rates and not survival. So this is lead time bias. Lead time bias occurs when survival time appears longer because the diagnosis was made earlier. Lead time is the duration of time between the detection of the disease by screening and detection of the disease It is the duration of time between the detection of the disease and its usual clinical presentation and diagnosis by the traditional criteria. So, lead time is the duration of time between the detection of the disease by screening or new experimental criteria and its usual clinical presentation and diagnosis by the traditional criteria. It is the time between an earlier detection through the screening and the time where its diagnosis would have been made in a usual clinical manner. It can lead to bias because if researchers start counting years of life or survival from the date of diagnosis, moving the date of diagnosis will make it seem like the survival is longer. Lead time bias is when a better screening tool for a specific non-treatable disease makes you think that early detection has increased the survival rate of the patients, but in reality it hasn't. To avoid lead time bias, we have to ensure that the researchers look at the age related mortality rates and not the survival. This is age related. To avoid lead time bias, we have to ensure that the researchers look at age related mortality rates and not survival. So, as we studied about bias, bias is any deviation from the truth caused by an error in gathering participants, performing the study, or interpreting the data. It can be of different types: selection bias or sampling bias, confounding bias, recall bias or response bias, confirmation bias, and lead time bias. Now, here we were mainly focused on lead time bias. Lead time bias occurs when survival time appears longer because the diagnosis was made earlier. The definition of lead time is the duration of time between detection of the disease by screening, in this case, which was a cervical smear, and its usual clinical presentation and diagnosis through the traditional criteria. Basically, it is a time between an earlier detection through a screening method and the time in which diagnosis would have been made in the usual clinical manner. The reason that it can lead to a bias is that if researchers start counting years of survival from the date of diagnosis, moving the date of diagnosis earlier will make it seem like as if the survival was longer. For example, a survival cancer patient when where screening was not done developed symptoms at the age of 65, died at the age of 70. Patient lived 5 years after the diagnosis. However, let's say in a different multiverse we had the same patient and this new cervical screening test somehow picked up her diagnosis at the age of 60 before she developed symptoms. She still went on to die at the age of 70. One may interpret this as she lived longer because there were 10 years between her diagnosis of cervical cancer and her death. But did the cervical screening test actually prolong her life? No. In fact, she died on the same day as she would have died without that screening test. The irony is that we probably worsened her life because in the second multiverse she suffered knowing that she had cancer for a longer period of time and the outcome was same. In the study above, researchers may not have extended the patient's survival time but have just picked up the disease earlier in time, so the 5-year survival rate looks better with the new smear test. So, lead time bias is when a better screening tool for a specific non treatable disease makes you think that early detection has increased the survival rate of a patient, but it really has not. To avoid lead time bias, we should ensure that researchers look at age related mortality rates and not the survival. So, lead time bias is a time difference between the diagnosis through the screening test and diagnosis through the clinical symptoms in a patient who didn't do the screening test or just by the traditional methods. Okay, now here is a case. Here is a question where there are a total of 10,000 patients who are studied to evaluate bowel cancer using a fecal immunochemical test. All 10,000 patients were screened for bowel cancer using FIT, that is fecal immunochemical test. Out of 10,000 patients, 1,000 patients had a positive result. All 1,000 patients with the positive result underwent a colonoscopy and biopsy, of which 100 of them had histology, which showed bowel cancer, while the remaining 900 tested negative. So the term for these 900 patients who tested negative. See, uh, these 1,000 patients tested positive with this fit test. So they were testing positive, but they were actually negative. These 900 out of these 1,000 were actually negative. So they did not have the disease, but they were testing positive. They were falsely positive. False positive is when the test incorrectly indicates the presence of the condition, in this case, bowel cancer. So these 900 patients who initially tested positive for FIT were found to have a negative biopsy result, which is termed as false positive. Now, a study was performed to compare esophageal cancer in individuals who are smokers with their matched controls. The study looked at the last 3 years of data. Individuals who smoked were associated with higher odds of esophageal cancer. What is this type of study? Okay, so as here we can clearly see, we have a group of individuals who are having the disease, whereas the other individuals who are not having the disease or who are controls. A case control study is a study where we compare patients who have a disease. We compare patients who have a disease or outcome of the interest or the cases with the patients who do not have the disease or outcome who are controls. And we look back retrospectively to compare the risk factors present in each group to determine the relationship between the risk factor and the disease. Again, it is a study which compares patients who have the disease or outcome of the interest, that is, their cases, with the another group of patients or people who do not have the disease or outcome who are controls, and we look back retrospectively to compare the risk factor present in each group to determine the relationship between the risk factor and the disease. These case control studies are observational because there is no intervention is attempted to alter the course or outcome of the disease. So goal is to retrospectively determine the exposure to the risk factor from each of the two groups. So these are retrospective studies, observational. They are often used to generate hypotheses that can then be further studied by cohort studies. So it would not be a retrospective cohort because here we are talking about uh, the outcome as well. We are not starting with the exposure. And it clearly mentioned controls as well. Okay, so cohort study requires forward flow of time, both from past as well as present, prospective as well as retrospective, to observe the outcome. Here, it is the previous data of patients of esophageal cancer along with the matched controls which are being compared. So smoking as a risk factor, a study concluded that those with smoking has more occurrence of esophageal cancer. So we are going retrospective here. That's why this is not even a retrospective cohort study, because the flow of time is not forward like it should be for a cohort study. So now let's just take a break for a while and we'll continue further. Okay, so let's continue ahead. So a small town has a population of 250,000, and in a 5-year period there was 1,000 cases of lung cancer diagnosed in that town. The neighboring town also has a population of 250,000, but only 400 people were diagnosed with lung cancer during the 5-year period. What is the annual incidence per million of lung cancer in the population of both of these towns? Per million is per 10 lakh of both of these towns. So both of these towns we have to add the population as well as the numbers of incidence cases. So the population will be 5 lakh, and the number of cases will be 1400, but they have asked per million. So in 5 lakh, if we have 1400 in a million, or 10 lakh will be 1400 into 2, that is 2800. Now they have asked annual, but this is representing 5-year period, so we have to divide 2800 by 5 and it will give 560 here. So here what we have to keep in mind is that incidence is a measure of the probability of occurrence of a given medical condition in a population within a specific period of time. So it is a incidence is a measure of the probability of occurrence of a given medical condition in a population within a specific period of time. Probability of occurrence of a given medical condition in a population within a specific or within a specified period of time. That is called incidence. Let's move on to the next one. 10,000 women were involved in a study looking at a new cervical test to detect cervical cancer. Thousands of the women who had this new cervical test had positive results. 100 of these women who tested positive had colposcopy and biopsy that showed negative results for cervical cancer. 10 of the 9,000 women who tested negative for the new cervical test had colposcopy and biopsy that showed positive results for cervical cancer. So, what is the most appropriate term to describe the now 9,000 women? So, as we understand here, 1,000 of the women had positive results out of these 10,000 women who were tested, and 9,000 others were actually they tested negative, obviously. These 9,000 women, so they just tested negative, that's it, according to the scenario. Now if we see 100 of these 1,000 women who tested positive, they showed negative results, so these are false positive cases. 100 of these 1,000, and 10 of these 9,000 women uh, who tested negative actually showed positive, so they were false negative. So these were These 9,000 women actually includes both. Uh, they simply tested negative. They were neither true negative nor false negative, neither true positive nor false negative. They just tested negative. So it's a tricky question here. The question is actually combining the false negatives and true negatives, which would give you the collective term tested negative. Simply, they tested negative. That's it. So, yes, that's what you have to go with. The value is the combination of false negatives and true negatives. So, false negatives and true negatives, their total will give you total negatives or who tested negative. Okay, let's move on to another one. A double-blind study was designed to test the efficacy of a new statin. One group of patients consisting of 425 patients were given a placebo drug. Other group of patients consisting of 501 were given the active drug. Both groups were to be followed for up to 2 years. Within the first 6 months, 25% of the participants in the placebo group dropped out of the study. 1% of the participants taking the active drug dropped out of the study. What is the single best explanation? So, as we see here, more participants in the placebo group have dropped out. So, and dropping out percentage is also 25%. So, it can't be a chance event because it is occurring within first 6 months. So, there are chances that the groups in the blinded trial were accidentally revealed to the researchers. So once researchers know which is the active drug and the placebo drug, they would unintentionally treat the groups differently. So double blinding means both the patients as well as the researchers don't have the information about which is the active drug, which is a placebo drug, which group is receiving what. So once researchers know what is the active drug and which is the placebo drug, they would unintentionally treat the groups differently. Given time, patients would soon realize if they are taking a treatment drug or placebo drug. Chance event in this context means that a specific cause cannot explain the people's withdrawal or dropout has occurred just by chance. The issue with this statement is the massive discrepancy in dropouts of the placebo group compared to the experimental group. There is a major difference in between the dropout of the placebo group as compared to the experimental group. An acceptable dropout rate between the groups is considered to be less than 15%. An acceptable dropout rate between the groups is considered to be less than 15%. Here we see a dropout rate difference of around 24% because 25% in a placebo group, 1% in the active drug group. So the difference is around 24%, which is not acceptable. Only less than 15% is acceptable. So furthermore, we would expect a dropout rate to be small given that the study is only for 2 years. A study of 10 years usually have a dropout rate of 20 to 25% at the end of the study, which is acceptable because patients often lose to the follow-up as it's a lengthy study. So dropouts not related to systemic bias could occur due to an unrelated illness, death, or job relocation. Selection bias is a bias introduced when improper randomization is performed. So it would not be a selection bias here because uh, improper randomization is not performed here. For example, people given the new statin drug are young, healthy, and the other ones are like old. So that would be a selection bias. So as an answer here, selection bias would not make sense. Now, if the active drug had serious side effects, Why this is not the answer? If the active drug had serious side effect, then it would be the treatment group which will see more dropping out cases, falls out of the study, as opposed to the placebo group. And the option that insufficient information is given, the insufficient information to come to a conclusion would be a good option to consider. However, the fact that if a research study is revealed to the researchers, dropouts eventually do occur with the placebo group, and therefore we believe this is the more appropriate one to go with. So the groups in the blinded trial were accidentally revealed to the researchers. So blinding was gone. Chance event is like somebody left for some other reason, like death have occurred or unrelated illness has occurred, job relocation has occurred, but the dropout difference is also mm, only less than 15% is acceptable, and in studies of like up to 10 years 20 to 25% is acceptable. For a smaller study like which is only for 2 years and after only 6 months such dropout rates are appearing, that is not acceptable. Now, 60 people are reported to be infected with the Hendra virus. This is the next case. 60 people are reported to be infected with the Hendra virus in a certain town. A short time later, in the town, 20 new cases are announced. 20 people with this infection are pronounced deceased, and 20 previously infected individuals are now cured. The current population of this town is 1,000. What is the current prevalence of the virus in this town? So 20 new cases, 20 new cases are announced. 60 people are reported to be infected. Short time later, 20 new cases are announced. 60 plus 20, that is 80. 20 people with this infection are pronounced deceased, and 20 previously infected individuals are now cured. So 60 plus 20, that was 80, minus 20 because they are cured now. So that would be 60. So So here we have to calculate the prevalence, or better say point prevalence, which we have to study. Existing cases plus new cases minus deceased cases minus cured cases divided by population and into 100. So PP in percentage will be equal to existing cases plus new cases minus deceased cases minus cured cases divided by total population into 100. That will give us point prevalence. So what is prevalence? Prevalence is the number of cases of a disease at a given time in a specified population. Now here it is reported as percentage, meaning that for every 100 individuals in this town, 4 people are infected with this virus. So it can also be represented in percentage or per 100 individuals. That is the prevalence, which is so that is the point prevalence we have studied. Point prevalence percentage is equal to existing cases plus new cases minus deceased minus cured upon total population into 100. Prevalence is the total number of cases of a disease at a given point of time in a specified population. It can also be represented in percentage. Now, epidemiologists are interested in prevalence because it allows them time to assess the overall burden of a disease in the population. This then provides public health officials with a useful measure to assess whether they need to invest more into prevention and or treatment services. As an example, prevalence of diabetes mellitus is on the rise in UK. It's on the rise in the UK, which is a worrying trend for public health officials and government. Okay, so what is its importance? Uh, Prevalence allows epidemiologists epidemiologists to access or to know the overall burden of a disease in a population. So it provides public health officials with info and measure to assess whether they need to invest in prevention or treatment services. Example, diabetes mellitus in the UK. Its prevalence is going high, so it's a worrying trend for public health officials and the government. Now, talking talking about incidence. Incidence is the frequency of new cases of a disease in a specified population. Incidence is a measure of risk. It tells us about the risk because new cases are arising. Definitely people are on risk, new cases are arising. So because it tells about the frequency by which the new cases of the disease are arising, or frequency of the new case of disease in a specified population, so it tells us about the risk. It is a measure of risk. For example, incidence of influenza is higher during the winter months, which indicates that a person has a higher chance of contracting it during these months, or chances to get or contract the disease. So more is the incidence, more is the risk of getting that disease, or more are the chances to get or contract that disease or infection. So incidence tells us about the frequency of new cases of a disease in a specified population. Frequency by which the new cases are arising. Frequency by which the new cases of a disease are arising in a specified population. It is a measure of risk, and it tells us about the risk of getting the disease or getting the infection, chances of getting or contracted the disease. It prevalence basically looks at all existing cases. Incidence looks at new cases or incidents. So exam writers really specifically state which type of prevalence needs to be calculated. Instead, you have to read the stem to deduce if you should calculate the point prevalence, which is more commonly asked, or period prevalence, which is less commonly asked. In this question, it is stated that current, which is a synonym of present or right now or instantaneous. This means that the question writer wants you to calculate the prevalence at a single point of time, or that is point prevalence. In addition, the denominator in the calculation of the period prevalence would need to be either the average population during the defined period or the mid-period population, neither of which are provided in this question. So that is another indicator that they are actually asking point prevalence, not period prevalence, because in period prevalence we need to have either the average population during the defined period or the mid-period population, and neither of those values are given. We just have current population of this town. Let us just go ahead and write down the formula for period prevalence as well. Period prevalence is equal to existing cases plus new cases upon average or mid interval population. Here is the population at the specified time. Existing cases plus new cases minus deceased minus cured upon population at the specific time into 100. That is point prevalence. So existing plus new minus deceased minus cured. We have to subtract both deceased as well as cured. That will give us point prevalence, and period prevalence would be existing cases plus new cases and divided by average or mid-period population, mid-interval population. We will not here consider, we will not be considering deceased cases or cured cases in period prevalence. We will just consider existing cases plus new cases, divided by average population or mid interval population. So now let's move further. A study on pulmonary embolism shows 10 patients out of 100 died who did not get treatment, and 10 patients out of 100 died who got proper treatment. So they are asking about the risk. Let me just go through the values. 10 patients out of 100 died who did not get the treatment, and 10 patients out of 100 died who got proper treatment. So here we have to just calculate the absolute risk. So absolute risk by definition is the percentage of people within a particular group affected by a certain event. Therefore, for both sets of patients who got treatment and those who did not, the absolute risk of death would be 10 by 100, because 10 patients died. It is a percentage of people with a particular group affected by a certain event. Ratio of the number of cases which develop the disease or which develop the case divided by the total number of people in that group. So for both sets here, it would be 10 by 100 into 100, because we have to calculate the percentage. So it would be 10%. Think of absolute risk as being the background incidence of the condition, in which in this stem the condition is death. So as we studied, absolute risk is equal to the number of events of the disease in a treated or control group divided by total number of people in that group. So absolute risk in control group, absolute risk in treatment group. Absolute risk in control group would be uh, equal to number of individuals with developed disease upon total number of individuals in that group. Just like that in the treatment group. Risk reduction would be divide control to subtract treatment one from the control one. That is absolute risk of the control minus absolute risk of the treatment, because we have reduced the risk. Risk reduction divided by absolute risk of the control group. Total number of individuals in that group who develop the disease, or who were affected by a particular event, we should better say. For example, in this case it is death, divided by the total number of individuals in that group. So absolute risk will be calculated like that, and we have to Keep in mind that we have to multiply it by 100 so as to calculate in percentage. If the answers are in percentage, we always have to take care of multiplying it by 100. Otherwise, we can end up with the wrong answer. Let's just note that down. Multiply by 100 if calculation in percentage. Okay, let's move on to the next one. Now, a study has been conducted which showed that 29 post-MI patients needed to be treated with aspirin to prevent one myocardial infarction. The 95% confidence interval is 2038. What is the correct interpretation of this data? So here we have to study about the number needed to treat. Number needed to treat is the average number of patients who need to be treated to prevent one bad outcome. It is the average number of patients who need to be treated it is the average number of patients who need to be treated to prevent one bad outcome. So number needed to treat is the average number of patients who need to be treated to prevent one bad outcome. So number needed to treat is calculated by 1 divided by the absolute risk reduction. So NNT NNT is equal to 1 upon ARR, that is 1 upon absolute risk reduction. So let's break down number needed to treat to make it easier to understand and go through some examples. Now imagine a new type of antiplatelet drug is invented. Let's call it Zido. A randomized trial was performed to test if this drug, Zido, reduces the risk of strokes compared to a placebo. What the researcher discovered is that for every 50 people they treated, they prevented one stroke. This means the NNT is 50. So it is the average number of individuals which are to be treated to prevent one bad outcome. The definition says it all. So in example 1, imagine a new type of antiplatelet drug which is invented. Let's call it Zido. A randomized trial was performed to test if Zido reduces the risk of stroke compared to a placebo. Researchers discovered that for every 50 people they treat with this drug Zido, they prevented one stroke. This means that NNT is 50. Here 1 is important to prevent one bad outcome. Number of individuals which are to be treated. So NNT is 50. Example 2. Imagine you are a part of a clinical trial. Your team develops a new drug which modifies cardiovascular risk factors. Now you assess the impact of taking this drug on the number of MI in patients who have had a previous MI or stroke. 100 patients are randomized to have the treatment. 100 are randomized to have clopidogrel. Participants were followed for up to 10 years. Now treatment with the new drug, which who developed MI10, who did not develop 90. Treatment with clopidogrel, who developed MI20, who did not develop 80. So the numbers treated to treat is calculated by 1 divided by absolute risk reduction. Now absolute risk reduction is calculated by subtract is equals to absolute risk of control group minus absolute risk of treatment group. So absolute risk of control group, that is which are given clopidogrel, uh, absolute risk would be equal to 20 divided by 100, or because it is equals to absolute risk is equal to the total number of cases which developed the disease or which developed the case or the event divided by the total number of individuals in that group. So absolute risk of the control group would be 20 divided by 100. Absolute risk of the treatment group would be 10 divided by 100. So zero point 0.2 and 0.1. So 0.2 minus 0.1, that will give us 0.1. So our absolute risk reduction will be 0.1. Now we have to calculate numbers needed to treat. So numbers needed to treat, we know NNT is equals to reciprocal of absolute risk reduction, or numbers needed to treat is equal to 1 upon absolute risk reduction. So it will be 1 upon 0.1, that will give us 10. So it can be interpreted as 1% would benefit by not developing a myocardial infarction for every 10 people receiving this new drug rather than clopidogrel over 10 years. For example, for every 50 people treated with a new drug, if one stroke is prevented, then NNT is equal to 50. It is the number of patients which are to be treated in order to prevent one bad outcome. So if, for example, if a drug is given to a certain group of people and for every 50 people treated with that drug, one stroke is prevented, this means the NNT would be 50. Now in case of the table, If data is given, we have to make the table, and then we have to calculate the NNT by the formula that NNT is equal to 1 upon absolute risk reduction. Numbers needed to treat Number needed to treat is equal to 1 upon absolute risk reduction. Now we know absolute risk reduction is equal to absolute risk of control group minus absolute risk of treatment group. Absolute risk of control group is equal to total number of cases which have developed, total number of people which have developed the case or which have developed the disease or the event, divided by total number of individuals in that group. Same way for both control and treatment group, we will subtract, we will get the absolute risk reduction, then n equal to 1 upon absolute risk reduction, and it will be interpreted as one person would benefit or one bad outcome would be prevented by for every 10 people, or for every whatever the NNT is receiving the new drug. So in this case, there is another option which can be confusing, which is that there is a 95% probability if we treat 29 post-MI patients with aspirin, we will prevent one heart attack. While it is a tempting answer, it might sound correct, but to a statistician would tell you it is wrong. The concept is somewhat abstract, and now the explanation will follow. The result of this study, which is a single study, was that 29 patients needed to be treated with aspirin to prevent one heart attack. 29 patients needed to be treated with aspirin to prevent one MI. So 29 was the NNT here. So number of patients that we need to treat with aspirin to prevent one NI is likely to be between 20 to 38. The 95% confidence interval is 20-38. The statisticians then perform their calculations, which are beyond the scope of discussion here. Based on the data of this experiment, concluded that 95% confidence interval is between 20 and 38. This means that if an almost infinite number of experiments were conducted in a similar manner to the original experiment, 95% of these experiments would generate a confidence interval that contains the true number of patients that needed to be treated with aspirin to prevent one MI. In contrast, 5% of these experiments would not generate a confidence interval that includes the true number of patients which need to be treated with aspirin to prevent one heart attack. So 95% is essentially saying that it is likely that the number of patients which need to be treated with aspirin to prevent one heart attack is between 20 to 38, but it need not be. So as a doctor, you will be required to read scientific studies and understand the statistical data. So 95% confidence interval, it means that if the same experiment is conducted, or infinite number of experiments are conducted in a similar manner, 95% of these experiments would generate the same confidence interval, which contain the true number of patients which need to be treated with aspirin to prevent one MI. So 95% will are telling that it is likely that number of patients which need to be treated with aspirin to prevent one heart attack is between 20 to 38, because it is given 2038. So that is what confidence interval means. It means if infinite number of similar experiments are conducted, then X percentage of these experiments would give true values between A and B. That is what confidence interval means. Okay, let's move further now. A total number of 10,000 women are studied to evaluate pre-malignant and malignant cervical lesions by smear. All 10,000 women were screened for cervical cancer using a smear test. 1,000 of these women had an abnormal smear. As a part of the trial, all 10,000 women also underwent colposcopy and biopsy. Biopsy showed pre-malignant and malignant lesions in 500 patients. 50 of those women who had pre-malignant and malignant lesions on histology did not have a positive smear test, which term accurately described the 50 women. It is saying 50 of those women who had pre-malignant and malignant lesions on histology did not have a positive smear test. So that means the test was negative. So it was falsely negative because their histology is positive. So they were falsely negative. 50 is false negative. False negative is where the test is incorrectly indicating the absence of the disease or the condition, whereas it is actually present. So 51 who initially tested negative using a smear test, were actually found to have a positive biopsy or histology results. This is termed as false negative. A randomized controlled trial was conducted to test the efficacy of an antidepressant drug called VFX. Group A received the drug and the control group received a placebo. The results revealed a p-value more than 0.1. Now the significance. So now we have to study about p-value here. P-values are a continuum between 0 and 1 to describe the statistical significance and provide a relative measure of strength of evidence against a null hypothesis. Now, to simplify it, if p is less than 0.05, it would be considered statistically significant, and a p value less than 0.01 indicates very strong evidence. A value of more than 0.1 would mean that it is statistically insignificant. So if p value is less than 0.05, it will be considered statistically significant, and p value less than 0.01, it will indicate very strong evidence. And p value more than 0.1 would mean it is statistically insignificant. So more than 0.1 insignificant, less than 0.05 statistically significant, even less than 0.01 very strong evidence. As p value here is more than 0.1, so it is not statistically significant. Evidence is not strong enough to suggest an effect exists. So we have to remember this thing. If p value, first of all, p value is a continuum between 0 and 1 to describe the statistical significance and provide a relative measure of strength of evidence against a null hypothesis. So if p value is more than 0.1, it is statistically insignificant. If p value is less than 0.05, it is statistically significant. If it is less than 0.01, it is having a strong, very strong evidence. Now let's move on to the next one. A study is trialing a new drug called CardioPrev for secondary prevention of cardiovascular events. The study seeks to determine whether or not Cardioprev reduces the risk of mortality compared to a placebo. In a randomized controlled trial, 100 patients were assigned treatment with Cardioprev, 100 control group patients were assigned a placebo drug. This means study duration was 60 months, that is 5 years. The mean average age was 63 years old. All cause mortality was 34% for Cardioprev, 40% for the control group. Which of the following represents the number of patients needed to treat to save one life with Cardioprev? So, what they are asking is just what we studied, that is, numbers needed to treat. Numbers needed to treat is the number of patients which are to be treated with the drug so as to prevent one abnormal outcome or one undesirable outcome. So number of patients which are to be treated, and it is calculated by 1 divided by absolute risk reduction. So absolute risk in here in the control group and treatment group. The absolute risk in the control group is here mortality is given 34% and 40% for the control group. So 40% for the control group and 34% for the Cardioprev. So we will subtract it. So 0.40 minus 0.34, and that is how we will calculate. The numbers needed to treat is the number of people which are to be treated with the drug so as to prevent one abnormal or one undesirable or one bad outcome. It is the number of how many people do we need to give an intervention before we have a desired outcome. The lower the number, the more powerful is the intervention. The lower will be the number, the more powerful will be the drug or the intervention. Lower the entity value, more powerful is the drug or intervention. An obvious example is parachutes. How many people jumping out of planes do we need to put a parachute on to save one person's life? Of course, a parachute is extremely effective, and therefore the number needed to treat is very close to 1. So NNT calculation 1 upon absolute risk reduction of the 100 people taking 34% of the people died, 100 people taking placebo 40% died. So value of these 2% gives us the absolute risk reduction. And do not forget that the percentage always gets converted to decimal points, that is 34 by 100, 40 by 100. We will subtract them. Absolute risk reduction 1 upon absolute risk reduction, numbers needed to treat. Now let's move on to the next one. The numbers needed to treat for the use of a new antiplatelet drug for the management of stroke is 21. What is the definition of the number needed to treat? The average number of patients. Okay, let me just go through the options. The average number of patients who needed to be treated with the drug so as to prevent one bad outcome. That is the answer. Numbers needed to treat is the number of patients you need to treat with an intervention or with a drug so as to prevent one bad outcome, that is death, stroke, MI, whatever it can be. This means that 21 people need to be treated with this new antiplatelet drug to prevent one person from having a stroke. So, this was it for this session, and take care till next time. See you.